Hello, my name is Carrie Dyer, and today I'll be completing a screencast explaining maternal role attainment / becoming a mother theory by Ramona T. Mercer. I will be explaining the theory, and I will also be explaining a case study in which we can apply the theory to clinical practice. Mercer's career has focused on maternal child nursing, where she's completed over 30 years of research on high-risk situations and transition into the maternal role. Currently, Mercer works as a professor in the Department of Family Healthcare Nursing at the University of California, San Francisco, where she lectures, consults, and writes. She's a recipient of multiple awards and was named an AAN Living Legend in 2003. AAN is the American Academy of Nursing. Mercer's maternal role attainment, becoming a mother theory, is based on her extensive education, her experience and research in maternity nursing. Mercer based her research on role, developmental, and systems theories. Her main purpose of the theory is to define and describe maternal binding in with the infant and achieving comfort in the maternal role. Initially, Mercer conducted a series of studies that focused on maternal role attainment in situations during the first 8 to 12 months of motherhood. And to describe the process of maternal role attainment, Mercer used Thorin and Nardi's 4 stages of role acquisition, being the anticipatory stage, formal stage, informal stage, and then personal identity being the last stage. Mercer describes the anticipatory stage of maternal role attainment to be pregnancy, a time of psychosocial preparation for the new role of motherhood. Then at birth, the mother moves to the formal stage of identifying her infant's uniqueness and begins the caretaking tasks by copying expert mothering behaviors and asking advice. She asks advice from friends, family, nurses, nurse practitioners, and physicians such as her OB and the baby's pediatrician. During the informal stage, the new mother progresses from rigidly following the advice of others to using her own judgment about how to best care for her baby. This stage of personal or maternal identity is characterized by the mother's sense of harmony, confidence, and satisfaction in the maternal role, and also attachment to her infant. The new mother now feels a congruence of self and motherhood. Mercer describes a framework for studying the variables that affect the maternal role. Maternal role attainment is described within the circles of the surrounding microsystem, mesosystem, and macrosystem. The microsystem is the immediate environment in which maternal attainment occurs. It includes factors such as the father's role, family function and relationships, family support systems, economic status, values, and stressors. All the elements included within the microsystem affect the transition to motherhood and are the most influential on maternal role attainment. The mesosystem includes the social systems that surround the microsystem, such as school, church, daycare, and other social systems within the immediate community. Interactions between the microsystem and the larger mesosystem influence the developing maternal role and the child. The macrosystem refers to the larger culture surrounding the family, such as social, political, and cultural influences that affect the other 2 systems. It would also include the healthcare system and health policies that might affect maternal role attainment. Mercer identified variables that influence maternal role attainment, such as maternal age, socioeconomic status, perception of the birth experience, early mother-infant separation, social stress, social support, personality traits, self-concept, child-rearing attitudes, perception of the infant, role strain, and health status. Infant variables would be things such as child temperament, appearance, responsiveness, and health status. Throughout Mercer's research, she compared 3 different age groups of women during their first year of motherhood. She looked at constructs such as self-reported maternal behavior, observed maternal behavior, attachment to the infant, and gratification in the maternal role. Looking at these 3 different age groups, she found that the majority, 64%, had achieved a maternal identity by 4 months. And then by 1 year, only 4% had not achieved it. Looking at the patterns of self-reported maternal behaviors, feelings of attachment for the baby, and observed maternal competence did not differ by age groups, although their levels of achievement did differ. Mercer's research has also included the role of the father and paternal attachment and competence as well. Mercer states that women's descriptions of the life-transforming experience of becoming a mother, along with the growth, development, and new self-definition, are not adequately defined within maternal role attainment terminology. The maternal persona continues to evolve as the child's developmental challenges and life's realities lead to disruptions in the mother's feelings of competence and self-confidence. This argument is made to replace maternal role attainment with becoming a mother to indicate the initial transformation and then continuing growth of the mother identity. So thus, Mercer revised her theory and retired the term maternal role attainment. The revised theory focuses on the women's transitions in becoming a mother, which involve an extensive change in life and require ongoing development. Mercer explains that becoming a mother is now much more than attaining a role. It's an unending and evolving event. Mercer continues to refine her theory with the use of her own research. In her 2004 article, Mercer provides a review of the nursing research related to maternal role attainment, where she provided new names for the stages in the process of establishing a maternal identity and becoming a mother. The first stage being commitment, attachment, and preparation, being the pregnancy stage. Second, acquaintance, learning, and physical restoration, being the first 2 to 6 weeks following birth. The third stage, moving toward a new normal, 2 weeks to 4 months following birth. And the last stage, achievement of the maternal identity, hopefully around 4 months. She states that active involvement in the first stage has been consistently linked to a positive adaptation in motherhood. She also states that the timelines for achieving the last 3 stages can be highly variable and may overlap as they're influenced by maternal and infant variables, as well as the social environment context. While becoming a mother continues to use the idea of nested environments, the environments have been renamed, such as family and friends, community, and society at large. They've been renamed to emphasize that these are living environments. Within the revised model, the center of the nested environments consists of the interactions of the mother, father, infant triad. The center is then first surrounded by an environment of family and friends and includes the variables of social support, family values, cultural guidelines for parenting, family functioning, and family stressors. Moving outward, the next living environment is the community, in which the variables are child care settings, places of worship, schools, healthcare settings, recreational and work and cultural settings. Then the outermost living environment is society at large and includes the variables of maternal child legislation, reproductive science and genetics, and national health programs. Mercer's theory of becoming a mother translates easily to the clinical setting and provides a structure for assessment, planning, implementation, and evaluation in nursing care. Looking at assessment, according to Mercer, you'd want to find out what stage is the patient in currently in becoming a mother. What's involved in her microsystem, her mesosystem, and macrosystem? Does she have support from family and friends? What about support from the community? What's involved in her greater society at large that's going to be affecting her at this time? What variables are affecting her most? Either positively or negatively. We got to find out what those stressors are. And then in planning, you would create a plan with the patient to help her understand how variables are affecting her maternal role attainment and then what she can do to address those variables. Implementation, you would implement the plan to achieve maternal role attainment or to continue to evolve in becoming a mother. Then lastly, you would evaluate if she has continued to evolve and develop in the maternal role over time. Now I will be applying a clinical case study using maternal role attainment becoming a mother theory. Looking at a postpartum depression case study, a 36-year-old married woman has just delivered her first child, a healthy baby girl weighing 7 pounds. Her labor and delivery were uncomplicated. She and her husband, who have been trying to have a baby for years, are thrilled about this child. She's discharged on postpartum day 2. Then 2 weeks after discharge, your nurse reports that the patient's husband has called in and has concerns about his wife's behavior. She's crying all the time, and last night she said she did not love her daughter and she wished she had not ever been born. He thinks she's just probably exhausted and is asking if she could have something to help her sleep. Looking at the assessment, you would refer to Mercer's stages of becoming a mother. This mother is most likely in the stage of acquaintance, learning, and physical restoration, being that she's 2 weeks postpartum. Further assessment is going to be needed. Given what the patient's husband has provided on the phone, really isn't enough information to devise a plan and action for this patient. So as the APN, I would ask the couple to come in and see me in the office as soon as possible to further explore what is going on. To understand the mother's situation better, I'd ask her to describe what she's feeling in regards to her relationship with her daughter and why she thinks she may be feeling this way. I want to understand what she describes her current role to be in becoming a mother. I then would proceed to find out what support systems the mother has within her various system. I want to know what variables are affecting her at this time. When I find out what exact variables or stressors are causing this disruption in her journey to becoming a mother, I can talk with her and find out that she feels that becoming a mother is much harder than she could have ever imagined. She feels regret that she wanted this baby so bad and tried so hard to get pregnant for so long, and now she feels that she's not as great of a mother as she could be because the baby won't sleep at all and has been very fussy. She doesn't ask her husband to get up with her for the baby because she can't sleep anyway, so she might as well stay up with the baby. She states that she knows the baby probably just wants to breastfeed, and her husband can't breastfeed her either, so what's the point of waking him up? She's not close with her family, and her friends all have older kids, and they haven't had much good advice for her, but she feels like being 36 years old anyway, she should know how to take care of her baby. So once we're able to work together and find out what's causing her main stress, we know that she's not sleeping. She's trying to take on too much on her own and complete all the care for the baby, possibly because she feels like it's her responsibility to be the sole caretaker. She also does not have support from family and friends, but really is she asking for help? Now we can plan together to find support systems for her and encourage her that it's okay to ask others for help, that she's not failing as a mother if she's not able to do it all on her own. She could find a support group at the hospital. Maybe also would want to make an appointment with the pediatrician to have the baby checked out if he's been more fussy to make sure he's not sick. Then we would implement the plan. Husband would be helping out more at home. She could ask friends to come over and help. She could join that support group at that hospital to gain advice from them. She could begin to pump her breast milk in order to have higher volume so that her husband can actually bottle feed breast milk to the baby at night, and then she could sleep more. So after you would implement that plan, you would then have her come back and evaluate if the action plan has helped or not. If it has not been helping, then you may want to introduce a medication. But if it has been helping, you would know because the patient would be explaining that she feels a better attachment with her baby and is explaining more support and feeling like she's gained or working towards that maternal role. So that concludes the presentation, and thank you for watching.